All right. Hello to you, our listeners, the manipulated and the manipulators. Welcome to the OMM Research Podcast. The OMM Research Podcast is produced by DO-Touch.NET, a practice-based research network that focuses on osteopathic manipulative medicine research. DO-Touch.NET is based out of the A.T. Still Research Institute, located at A.T. Still University in Kirksville, Missouri. Please note that the views and opinions of the panelists in this podcast are personal to each panelist and do not reflect the views or opinions of A.T. Still University. My name is Corey Lubring, and I am the host of the OMM Research Podcast. And we want to remind our listeners that this podcast recording has video recorded with it, and it can be viewed on the DO-Touch.NET YouTube channel. As always, we want to start our episode by introducing our panelists, and we're going to start with Dr. Amendolara.
Hi, my name's Amendolara. I'm a PGY1 at St. Luke's University Health Network in Bethlehem, and also an adjunct faculty and research at Nordic College of Osteopathic Medicine.
And thanks for being with us this month, and we also want to introduce Dr. Stephen Stacey.
Hi, my name is Stephen Stacey. I'm the Director of Osteopathic Education for the La Crosse Mayo Family Medicine Residency Program, and I am the research lead for the residency and an assistant professor of family medicine at Mayo Clinic.
And thank you both for being with us this week. We have some really interesting articles that we're going to be breaking down, and we're going to be starting with an article by Dr. Amendolara that is going to be looking at OMT for enhanced pitch performance. And so, would you like to give us some background on this article, Dr. Amendolara?
Sure. This article is called Osteopathic Manipulative Treatment for Enhanced Pitch Performance in Collegiate Baseball Players, a Feasibility Study on Shoulder and Hip Interventions by Roston et al., and it was just recently published in Journal of Osteopathic Medicine in January of this year. So this study, I think their initial goal was to look at improvements in pitch performance using muscle energy and Spencer's techniques. But really, their primary result ends up being, I think, injury reduction. They got some baseball pitchers from a college baseball team and offered to participate in this. So I think they had 16 total pitchers. 13 of them ended up being randomized into an OMT and control group. This was a prospective study. They ended up with 6 members in the experimental group and 5 members in the control group. And I believe they did do a crossover at some point. They did a whole range of statistical testing on things like joint angle and velocity, hip extension, things like that, kind of all sort of biomechanical, and then also looked at incidence of overuse injuries. And their main conclusion is that a single application of the OMT helped prevent overuse injuries in these athletes. And they also found some differences in velocity, range of motion, and then the injury risk. But this is all tempered by their very low sample size.
Sure. Could you give us a little bit of a deeper dive in the methodologies that they use? Like, what was the protocol for this particular study?
Sure. So this was, I guess you'd call this a prospective, randomized. It's not really a trial, but cohort study with a crossover. So they assessed a group of participants for eligibility. It sounds like this was really done by kind of convenience sampling. They went to a local college and asked the pitchers if they'd like to participate. They included participants based on whether or not they were actively playing baseball, and really excluded anybody who was either injured or otherwise prohibited from playing or practicing. Um, that's really, and of course they had to have permission from their coaches. They ended up randomizing them. These were all right-handed pitchers, for those who are interested. Um, they initially followed up after 5 weeks, and then they did a crossover. I think they ended up, out of the 5 initial control groups, 3 of them ended up receiving a treatment, and then they did all kind of their analysis. I don't have too much information on exactly what their protocol was. They say their treatment group received Spencer's technique and muscle energy, and then they say some fascial distortion model, direct inhibitory pressure, um, hip rotation, ligamentous articular strain. They sort of list a variety of techniques. I believe they have a nice figure here, figure 2, where they kind of highlight exactly where they targeted, and Corey, I don't know if you want to show this. It kind of I think
Yeah.
it's a cool
I have it
um,
shared here in Discord
graphic.
for us.
Yeah, it just shows the kind of the biomechanics of pitching and where they tried to focus their intervention, which I think is nice. It gives us a reasonable target for their therapy. Um, They go on to say that they applied their various techniques to all these different joints, kind of roughly following this outline, and then they followed these people for the 5 weeks, and then the crossover. Their primary outcomes were speed, velocity, or release speed, velocity, um, height, horizontal break, pitch extension. They have a whole list of these. They also have a number of secondary outcomes. And then they used t-tests to compare some of these, and then they also used a Fisher's exact test to look at the incidence of injury. I think, and they also assess these for normality. There's a couple, I think, issues with their statistical analysis. They did a lot of analysis here. This is, I'm not a huge fan of shotgunning statistical tests, especially without any sort of consideration for correction. I don't know. I think there's an argument for not doing correction here because this is mostly exploratory, but certainly with several dozen statistical tests, I think it becomes a relevant question with these low end numbers. I suspect that had they applied any sort of correction, that there's a strong chance that these wouldn't have remained significant. Although they don't mention it, so they very well may have corrected within the software
I
or
think one of
something else.
the things looking at all of these statistical tests is people looking at the tables and looking at significance might conclude that what the statistical test shows is clinically true across the population.
Yeah,
And that wasn't really what this study was well designed for. Um, and and I don't know that it ever meant to be that. I think that it maybe shouldn't have been published in a clinical journal, just because it's something where people reading this might say, well, the evidence now concludes that it's effective for doing this thing. If this were a biologic or a device or a drug that was trying to get approved by the FDA, this is really what we're looking at here is a phase 1 trial. It's taking a concept and introducing it into a population, not even necessarily a sick population, but just seeing, is there some type of an effect of the treatment at all? And a lot of what they're doing is shotgunning for effect, as you mentioned, but it could also
mhm,
help inform targets for future studies, which I think is pretty reasonable. But it's just
yeah.
not framed that way in the presentation of it.
I agree. I actually think I think when you look at this through the lens of a more basic science approach, their methodology and the way they approach their statistical analysis makes a lot more sense. They did assess for normality, which I think is reasonable here, but um, they then go on to exclude anything that was non-normal, which I don't know if that was the right decision. There are non-parametric tests. I think there's an argument for not kind of arbitrarily excluding things based on normality. That personally is not something that I've seen done in the past. So I'm not sure what their justification for excluding those are, other than they didn't want to mix statistical testing, which I think isn't unreasonable, but I'd like to have seen some justification for that. Strictly speaking, their statistical tests are reasonable. A t-test is perfectly valid for low ends, but I think in a clinical context, it's a little bit harder to draw any conclusion from this. From a more basic science, like experimental, I don't think an N of 5 and 9 for a control and treatment group is completely crazy for an exploratory analysis, but,
No, I think it makes sense. Again, if you think of it as a phase one trial, which
yeah,
means, who should the audience be? The audience should be funders that are looking to say, could we give money for a larger study? I think this really is good introductory work and shows proof of concept and that there might really be something there. The audience, though, of this journal really is clinicians more than funders, and where the conclusion they put in, a single application of OMT is a low risk intervention to prevent overuse injuries in the elite overhead athlete. I would count that in maybe more tepid terms, say something more like, this analysis is consistent with effectiveness of the treatment rather than it
well,
shows effectiveness of the treatment, because you really just can't conclude enough about the broader population from such a small sample
right.
size.
They also lost, 2 of their control, pitchers to injury, which, is kind of interesting. In the results, they attribute prevention of that injury to OMT. I'm not really sure that their sample size and their study design supports that necessarily. It's certainly an interesting finding, and I think it could be real, as you're saying, as a guidance for future research or as a proof of concept to acquire funding. But, from reading from their methodology, I don't see any sort of risk stratification for injuries. Obviously, at the beginning of the study, no one was actively injured, but I don't see any attempt to stratify the participants based on how frequently they were pitching, how frequently they were practicing,
Yeah.
any, we'll say, extracurricular activities. We have no idea if these people were
Well, yeah, they couldn't have
involved in
really.
outside activities that could predispose them to injury, if they had prior injuries that would predispose them to injury. There's a lot here that sort of confuses it, and then, of course, when you have a very low sample size and loose control of your variables, I
Yeah.
think your results end up being a little bit less reliable,
And
which
you
is
also
really
bring up one thing that you brought up, Al, is what they did with the people that didn't meet the protocol, and really what you would expect to avoid the risk of a false positive is to include dropouts in the analysis, which
Mhm.
they didn't do. So standard of practice really is to do an intention to treat analysis versus they did a per protocol analysis, which the bottom line there is it's going to bias towards effectiveness and
Right,
introduce the risk of a type 1 error or false positive.
So what
right.
would you both recommend kind of as next steps for a study on the same tracks?
I think this is a good start. Again, it really depends on how you frame this. From the perspective of a researcher looking for a foundation for future work, I think this is useful. I think unlike a lot of research that we've talked about and that we read in the osteopathic field, there's a reasonable biomechanical background. Pitching in it fundamentally is made up of a number of complex biomechanical movements that can be impacted by all sorts of muscle and fascia issues. And certainly OMT could be reasonably expected to at least prevent injury or improve joint mobility. I don't think I think that's starting from a pretty reasonable foundation. And so looking at this, and considering that this is primarily exploratory, you could certainly pick through here and look and see, well, what are we most interested in continuing on with? And then design a larger study that's a little bit better controlled, meaning the participants are a little more carefully selected. The protocol is a little bit more rigid. There's a little bit better follow-up, things like that. And I think you could get some useful information. Personally, I would like to see injury be the main focus. I think our best or the most likely improvement that we would see that would be clinically relevant for us is injury prevention rather than sort of esoteric improvements in joints, range of motion, or pitch velocity, things like that, that I really wouldn't expect baseball players, at least at the college level, to be going and getting their regular OMT to get, a fractional improvement in pitch speed, especially based on a study like this. So from a research perspective, this is a good foundation for further studies. From a clinician perspective, I don't think there's much you can do with this. I don't think anyone would fault a sports medicine doctor or a team physician at a college for doing OMM. I don't see any indication from this or other research that there would be a risk to doing it. But I don't think that this would inform or change anybody's practice with regards to particular treatments or a particular population, if
Sure.
that makes sense.
Yeah. Well, thanks for bringing that article to us this month. We do want to remind our listeners really quick that if you do want to see us as we are discussing these articles, there is a video recorded with this episode that is viewable on the DO-Touch.NET YouTube channel. That's do-touch.net YouTube channel. So our second article we're looking at this episode is brought to us by Dr. Stacey, and it's looking at pain outcomes of patients treated by osteopathic and allopathic physicians.
That's right. The title is Chronic Pain Outcomes Among Patients Treated by Osteopathic versus Allopathic Physicians, a 36-month follow-up study. It was published May 23rd, 2025 in the Journal of Osteopathic Medicine. The lead author is, you guys need to help me with this one, Licciardone?
That's how
Yeah,
Licciardone.
I think that's how I say that.
Licciardone? Okay. My apologies to Dr. Licciardone. I've actually been a fan of a lot of his research, and I think this is a decent study. The study looks at it's a secondary analysis of existing data from the Precision trial, which we'll talk more about, looking at whether patients treated by osteopathic physicians have better low back pain outcomes compared with treatment with patients treated by allopathic physicians. And their conclusion was the study found that patients with chronic low back pain treated by osteopathic physicians reported better outcomes for pain, function, and health-related quality of life than patients treated by allopathic physicians over 36 months of follow-up.
All right. Well, can you give us a little bit more insight to, kind of what the study's about, what some of the methodology was?
Sure. So the Precision data set is an ongoing trial looking into chronic pain outcomes, and this is a secondary analysis of that data set. So it began in 2016 as a prospective case control study. So two cohorts of patients were selected, some with low back pain being the cases and some without low back pain being the controls. And then they took the data set in 2024 and started analyzing retrospectively then whether the low back pain cohort of patients had better outcomes when they were treated by an allopathic physician versus an osteopathic physician. And they looked at a number of different outcomes like low back pain intensity, back-related disability, frequency of chronic widespread pain occurrence, and chronic low back pain recovery. And they found that some of them differed between the allopathic and osteopathic physicians, specifically chronic low back pain intensity and back-related disability. And then the frequency of chronic widespread pain and chronic low back pain recovery did not differ between the groups. Now, I will say the absolute differences between these are small. So if you look at low back pain intensity, for example, it was 14.8 versus 15.6, and they had they had, from there a less than 2% absolute difference between the two groups, which I'm impressed that they found any difference at all, given how many variables would exist between one physician type and another. But as you look at the differences here, one thing I wanted to highlight is illustrated in Figure 2. And you can really see how the differences between the two groups changed over time. So for those of you on the podcast, what it looks like is we have these different groups and how they work over the 36 months included in the study here. So mean low back pain intensity, back-related disability, quality of life, and pain impact. And what you can see is on the left side, so when the study was beginning, the confidence intervals were a lot more narrow, and the division between the DO versus the MD group was a lot wider. And that difference narrows as the study progresses for pretty much all of the outcomes, and also the confidence intervals get a lot wider, which is what you would expect just naturally through regression to the mean, which is what happens when you follow patients for long enough. The sickest patients are the outliers, and over time, outliers tend to come back towards the mean for the population. And so for that reason, you expect, in a lot of natural history of disease studies for things to just improve. And so the fact that they continued to find a difference, even considering the fact that it was attenuated towards the end of the study, I think highlights how much bigger the difference was right at the beginning.
Interesting. And then you also were mentioning something about Figure 3 prior to us starting the episode.
Yeah, and so that shows the two that were found to be non-significant, and you can really see there how from the left to the right, so for the entire 36-month period of the study, there's really overlapping confidence intervals, and these lines go back and forth quite a bit. And so just visually, you can see that the ones that were different, you can see the portions that were the more different, the more separated, more towards the beginning, but also that the absolute difference is not large in a lot of these.
Sure. So what are the key points that you all would like to kind of bring forth, to our listeners, about this study? What are the things that really stuck out to you, good or bad?
So one thing that I noticed was I would have liked to have a lot more insight into the methods behind a lot of these things. So for example, one thing they say is that a lot of the difference, as they looked at the different physician level factors that mediate the difference the most, they found that physician empathy and the use of osteopathic manipulative treatment were the two factors that made the most difference or explained most of the difference between the two groups. It's hard to know exactly whether OMT was used, though, because what they say in their methods is that patients treated by a DO and receiving spinal manipulation were considered to have utilized OMT, versus patients treated by an MD and receiving manipulation were considered to have other types of manual care. And just the way it's phrased tells me that they didn't gather primary data on whether it was OMT or some other type of manual therapy. So it's not an unreasonable assumption that it was the DO doing the manipulative therapy, but also I'm sure a lot of those were referred out by the DO, just the same as would have happened referred out by an MD.
And it's not clear to me, at least reading their methods, that they even included manipulation if it was referred from an ND. I don't know that that would change the results necessarily, but it's certainly a consideration. Earlier on in their inclusion and exclusion, or their description of how they segregate the data, they mentioned that they excluded patients who were primarily treated by physiotherapists or chiropractors, or what they say other non-physician practitioners. And then later on, they say that patients treated by NDs who received manipulation were considered to have been treated by chiropractors or physiotherapists, or other non-physician providers. So my assumption from that, or I think the implication is that they didn't include that portion, which I think certainly muddies the waters, and raises the question of whether or not we're excluding other manual therapy from NDs. And then, like Dr. Stacey is saying, we're not excluding outside manipulation when it comes to DOs.
Yeah, and they might have been doing something else, right? Like maybe
Right.
patients
But it's hard to
self-identified
tell.
who their primary was, and if it wasn't a physician, they were excluded. But you're right; it's hard to tell from how the methods are described in this manuscript. So that does temper some enthusiasm that I might have for it, simply because you couldn't really exclude um, some amount of cherry picking of the data based off of how it's reported. Another thing that would have been nice to see reported is blinding of the statistical analysis. So I don't see that the people doing the analysis were blinded to group, which could potentially introduce some bias as well, as people may select interventions or statistical tests that favor the preferred hypothesis. Um, and
I would
again,
agree with that. There's a lot of statistical analysis going on here. I think it's reasonable. I think their general approach is perfectly valid. Well, we don't have to get into the weeds with it, but it seems reasonable. But a lot of their decisions are not necessarily, I think, clearly explained or justified, at least with regards to how they're binning the data, what they're considering OMT. My assumption is that they divide this by primary care or primary provider between DO and MD, but I think most of us would agree that it's rare necessarily to have a patient only seeing a single doctor. Um,
yeah.
I think that muddies the waters too. What's to say that, and I don't think I can answer this based on what's written, but what's to say that patients weren't seeing multiple specialties, and how might that impact back pain? Certainly, if someone's seeing pain management specialists or DO as their primary care, but may not be primarily managing the low back pain. There's a lot of questions about how exactly or what exactly the details of the individual patient data, how it was collected, how it was kind of grouped together.
So if I were just reading this manuscript and trying to get a clinical interpretation from it, the bottom line from the authors would say that patients who are treated by DOs do better as far as back pain goes, and that it seems that the DOs who used more OMM and had more physician empathy did better. I think for a couple of reasons that last bit of the conclusion is a little bit harder to reach. So we talked about how there are potentially other explanations for how osteopathic manipulative treatment and the way it was reported and statistically analyzed may have other explanations. For the physician empathy, it looks like the data about empathy was only gathered once at the beginning of the study, at least from the way it looks in their methods, versus the other data was gathered longitudinally. And what we saw is that the difference really was biggest at the beginning. So if there were another measurement that was measured only once at the beginning, that might also show up as potentially being more meaningful in terms of an explanatory variable, because it did not suffer from regression to the mean the same way a lot of the others did. So that tempers the conclusions a little bit, but I will say, given the data set that they had and the questions that they're trying to ask, I think that this is decent evidence in support of the osteopathic model of care. I don't think that it goes to the level of being fully practice changing for a health system level. I think that it could be successfully used in a larger analysis, like a meta-analysis looking at differences. This certainly would be data that would play into that analysis. But I think that it would be hard to necessarily change our practice based off of the results of this study.
So where would you see the study going? Where would you take this study for like next steps?
I think it would be great to see this same question answered using other data sets. I think that they did fine with the data set that they had. I think that this I really think it was a cool way to use that data set. And I think that this study was worth publishing. I would like to see other analyses and maybe even ones that come from non-DOs, maybe not even non-physicians, because if we were to look at, again, some of the things that ideally could have been better about this, I would have liked to see a little bit more highlighted in the methods about exactly what their decisions were. And it would have been really great to see some blinding, to just trust some extra level of bias mitigation.
Sure.
Yeah, I just want to throw out there that I agree. I think this is an interesting study. I think they did a fairly good job with their analysis. My biggest complaint, and I think the biggest room for improvement here, is that I think any sort of secondary analysis of trial data like this, or of an existing data set, one of the most important features that I look for in a paper is a really good explanation of the underlying data itself, why certain decisions were made, how that data, even so much like how that data was collected, how it was processed for the secondary analysis. And I think a lot of that's missing. And to me, as we're talking about the limitations and how to temper their conclusions a little bit, I think that's the part that's missing. So I don't think that I would necessarily go back and change anything about this study, but I think if we were to do something similar with other data sets, or kind of use this in a meta-analysis, what I would like to see is greater attention to what the underlying data that they're basing this off of looks like, why they're making certain decisions, and sort of how they're coming to the conclusions, not from a statistical standpoint, not from a results standpoint, but from a methodology standpoint.
Well, we want to thank you both for being with us this month. We do want to just remind our listeners really quick that if you want to find out more that's happening within DO-Touch.NET, you can go to our website, which is DO-Touch.NET, to find stuff that's happening within the network. I will say that the month that this episode is being released, which is going to be March, we will be at AAO Convocation in Colorado Springs with our booth at that event. So if you would like to come say hi to us, you are welcome to come see us at our booth and meet me in particular. Dr. Stacey is usually there at Convocation as well, representing the Mayo Clinic, and we would be happy to dialogue with anybody that wants to come and talk with us.
Yeah, I'm definitely going to be there at Convocation, and I just want to put in a plug for the booth that we'll be at too. We're going to be talking about our residency program, but also the Mayo Osteopathic Research and Education Conference, which is going to be this year, September 18th to 19th in Rochester, Minnesota. And it's a conference where we talk about all things osteopathic manipulation, the practice, research, and education. It's a really cool conference, a lot of great energy there. We'd love to see you.
All right, and thank you both very much for being with us this month, and we'll see you all next time.
Thanks.
Yeah, thank you.